A lot of confidence, very clever. He was a very clever personality. And he also used to make us laugh. You know, he had jokes, plenty jokes. People didn't know that side of Dingaan. They knew the side where Dingaan would fight. But as we grew older, he was a friend of mine. He was a close friend of mine. I used to be on the phone with him daily, you know, talk to him. We had plans about him coming back, opening a lot of his gyms in the townships, in the rural areas. And we also had planned a podcast. Me and him was going to co-host a podcast.
Moving with the times.
Moving with the times. But such a wonderful person, and he will be sorely missed.
And a groundbreaking new gene therapy has enabled an 18-month-old girl in Britain who was born deaf to hear. The treatment took place 6 months ago, and the child, Opal Zandi, can now hear sounds as soft as a whisper and is starting to talk. More from the BBC's Michael Roberts.
More than half of hearing loss cases in children have genetic causes. Opal's is due to DNA she inherited, meaning she was born deaf. The groundbreaking therapy uses a harmless virus to deliver a working copy of the OTOF gene Opal needs for hearing. That treats sound sensing cells in the inner ear so they can carry the signals they should. Experts hope in the future the therapy could work for other types of profound hearing loss too.
Recapping the top story, Labour Minister Thula Singesi is expected to brief the media following the collapse of a multi-story building in George in the Western Cape. For SAFM News, ke Modupi Makgalemele.
SAFM 104 to 107 nationwide.
The Freedom Front Plus is a political party that has a plan to rebuild South Africa and provide equal opportunities to all. The party's policies provide real solutions to the problems facing the majority of South Africans. We do not only need a new or better government, we need a new dispensation where the power is restored to the people, where communities can make their own decisions about what is important to them, where the economy grows and everyone is afforded the opportunity to prosper. To realise this new dispensation, vote for the Freedom Front Plus.
Let's rebuild South Africa. Vote Freedom Front Plus on the 29th of May.
This political election broadcast was brought to you in terms of the CASA regulation governing the election period. The views expressed in this political election broadcast are those of the political party and not of the SABC.
Getting more money into your pockets has never been this simple and exciting. With SABC's new Simple Watch and Win game show, you can get more Zaga in your pockets. Catch more Zaga every weekday on SABC 1 at 9 p.m. You could win your share of 50,000 Rand. All you have to do to win is give the correct answer for the day. Just dial star 120 star 332# to register and play. The cost is R1.50 per minute. You could win big with more Zaga, only on SABC 1.
Things are really heating up in the Tastemaster kitchen this week as we enter our first elimination challenge.
This week, we celebrate our African pride and see who will rise to the occasion.
10 minutes left and I'm still doing my curd.
Things can go wrong very quickly.
What I'm doing to try and finish on time is pray.
Join us 7 p.m. on SABC2 every Tuesday.
Repeats on Wednesdays at 2 p.m. and Sundays at 4 p.m.
See you there.
Support Slipper Day on the 31st of May and help children like me fighting life-threatening illnesses to reach their dreams. Visit reachfordream.org.za and make a difference. And don't forget to step into your slippers on Slipper Day. Reach for a Dream, inspiring hope. This is an SABC-supported initiative.
The Talking Point with Cathy Mohlahlana. Weekdays, 9 a.m. till midday.
Morning, Cathy. This is Magdalene from Bloom. Cathy, you said the mouthful long time ago. By the time you start this conversation, that tender, it was intentional. Whether the service provider qualifies or not, or meet the requirements or not. It was intentional, self-enrichment and looting from the government. That's all. It's all over. It's all over all the municipalities. Even here in Bloemfontein, they just give it to service provider for the sake of looting. Even if the service provider doesn't qualify. It's still happening even now. Magdalene from Bloom, thank you.
Morning, Cathy. It's Mike from Cape Town. Cathy, I'm a bit worried about this. All your panels there, seems like no one knew about this thing, except for anonymous reporting or tipping you about this corruption taking place. What are the councillors and all those people there doing? So that means anyone can do anything. As long as no one knows, they can get away with murdermus. What's happening? The councillors are there, but no one knew about this. If they were having oversight of everything, no one knew about this. This is very worrying, Cathy.
Morning, Cathy. If a bowl is 500,000 and gift of the givers is doing it for free, we're wasting our times by paying these people. Rather give gift of the givers something. Let's donate for gift of the givers to do these jobs, please. 500,000 for a bowl, come on, man. It's less than 60 or 50,000. Thank you.
Hi, Cathy. It's Ozzy here from Midrand. Cathy, So I think the cost of the borehole, yes, I understand why people are surprised, but it's important as well to understand: is it referring to just the cost of drilling, or is it referring to the cost of a project? When I say a project, is a project to drill a borehole, because there are other costs, professional fees, some fees of study that also plays a role there, and that can push the cost to over 500,000. So, but on a face value, just to drill a borehole should be anything less than 200,000. Thanks, Cathy. Bye.
Cathy, this is Zanele in Durban. Will you please ask your guest from eThekwini Uguti why they are no longer using the customer care line now? Because that WhatsApp line is not helping. It's just useless. Yeah, they do give us the reference number through that WhatsApp line. But if I have to do the follow-up for my complaint, they only just say, no, you are on the queue. And it takes months and months. They don't attend to the problem that you've been complaining about. Thank you.
Morning, Cathy. I'll suggest the government do a lifestyle audit to all the workers of water and sanitation under eThekwini. You see those people are driving nice cars, they are staying in double stories, even the clerks, everyone should be audited. You'll see how much corruption is there.
All right, those were just some of your responses to our 10 o'clock conversation and focus on the eThekwini municipality in our Municipal Watch feature. Like I said, we will do a part 2. We will follow up on this particular issue, especially given the commitments from the political parties to investigate it further and have it be a matter that council gives attention to. Well, coming up this weekend, the nursing fraternity will be commemorating and marking International Nurses Day. This year, it's under the theme, Our Nurses, Our Future, the Economic Power of Care. Now, what we know is that in a country like South Africa, we still have a very high nurse-to-patient ratio. It currently sits at 224 patients to one nurse. And this creates lots of challenges, you can imagine, for the nurses themselves as they have to go about their daily duties and responsibilities. Well, Dr. Unben Pillay is a medical doctor and is an independent medical doctor who's also involved in digital health and advocates for nurses to use digital health platforms. Dr. Pillay, good morning to you.
Good morning, Catherine. Good morning to your listeners.
Tanya Joffe is Chief Executive Officer of UNO Health. Tanya, good morning.
Hi, Cathy. Thanks for having us.
Firstly, let's talk about the use of technology in the provision of healthcare services. I've noticed recently you go to your doctor and they don't even give you a physical script anymore. You just have to go to whatever pharmacy of choice and they're able to pick up your script. There's been some developments in the system that have moved things from being paperless.
Yes, definitely. So I think the future of healthcare is digital. And what we've seen is post-COVID, we've had an enormous change in how we treat patients. We've moved into a digital space a lot because of COVID in terms of how we interact with our patients and what we can do. So as much as there was a lot of bad with COVID, the good part was that I think it's transformed the way we see patients and treat patients to make it much more convenient for patients.
The difficulty, though, is that if you don't have your physical script, one pharmacy has some medication, then you have to go to another pharmacy, and then when you get there, you have to prove that you didn't get what you said you need from the other pharmacy. So while the system is progressing, the communication not quite there yet.
Yeah, I mean, I think we're all in a bit of a learning curve. So we're moving into a paperless environment. Not all our practitioners are there yet. But I think for the patients, the understanding is to be more convenient. I mean, the ability for patients who aren't able to come to the practice to pick up a script means that we can now email it directly to the pharmacy. They can go to the pharmacy without needing to, wait in long queues or take transport. So there's lots of benefits in terms of the electronic scripting. But I think we're definitely progressing and getting better at it.
Tanya, this conversation in the context of nurses that barely have time to do their own filing, nurses that are having to deal with so many patients on a day-to-day basis that they're simply overwhelmed just with running up and down the corridors of the facilities where they work. What role do you think technology is going to play there?
I think the role is really significant. So we see in our own business model, so UNO Health, which is an app which your listeners can download, and I'd love to get feedback. Basically, we have nurses as an entry point. So if you're on the app, you can chat to a nurse for 95 Rand, literally from your phone immediately, and you pay on the app. So, and that consult will be maybe a 5, maximum 8-minute consult. So it's very, very efficient if the nurse is enabled with the technology. And she can support that. So we work with Intercare, who have a digital nurse clinic, effectively, that our users can then access. Equally, we work with them on the GP front, where you can also access a doctor for 179 Rand. But the scenario that you described is the reality for many nurses in South Africa that work, especially in the public healthcare system, in the clinics. They have the filing. Often to find a patient file is a challenge, so that makes continuity of care a challenge. The medication, they often stock their own rooms. There's nobody stocking their rooms, so then to find the medication and script. So it's and it's because of the demand. The demand exceeds the capacity. So I agree with Anbin, Dr. Pillay, that we need to leverage technology to make it more efficient, more accessible, more convenient, and have our resources go much further.
Do you think that as a healthcare system overall in our country, we are putting enough emphasis on the role of the nurses and primary healthcare? Because that's where you would interact most directly with nurses when you're going to a clinic for whatever service you may need.
I can't agree more, but I think, Anvin, I mean, you quoted some stats to me the other day that were just fascinating in terms of private healthcare and how much is spent on primary care versus specialists versus pathology. And it doesn't paint a good picture, does it?
Yeah.
Sure. So I think primary healthcare has to be the foundation of any healthcare system. I mean, I think the starting point in healthcare has to be in the primary healthcare, and that's made up of both nurses, general practitioners, clinical associates, pharmacists, and I think that's really where we need to focus the majority of our fund and our spend. Unfortunately, in the private sector, the spend in primary healthcare is very minimal. I mean, in the GP space, it's probably now just under 4% of the primary healthcare spend.
Sure.
Which means that, our key and our focus is not on primary healthcare anymore. We've shifted away to a more hospice-centric model. But as a country and as in the public sector, primary healthcare by far has to be the priority for us.
What do you think then becomes the cost to society overall of this lack of emphasis, lack of support for primary healthcare?
So we've seen the shift now. I think in the last 10 years, especially if we talk in the primary healthcare, we've seen a shift away from primary healthcare into more specialist care and hospital care. And that has driven the cost up to an unaffordable rate. We have to move back to primary healthcare and we have to have that gatekeeper role. Because with the gatekeeper role, you're going to control costs. You're going to be able to do things which are much more affordable and only when necessary refer patients on for more specialized or secondary care. So definitely the shift, both in the public sector or private sector, is moving back to primary healthcare as the key, as the cornerstone for healthcare.
Tanya, how much of it, and including just with the app that UNO Health has, how much of it also requires individuals to have a certain level of faith and confidence in the role that these different practitioners play, right? Because, you're right when you say that there's a lot of emphasis on specialists. And today, most people, if all they have is a cough, they're already thinking about which specialist can I go and see. And that's not necessarily the way it's supposed to be, right, Tanya?
Agreed. So it's interesting because, what we see is we are actually piloting right now with one of the big retailers, and we have, I was sharing earlier, we have an electronic nurse. So she's 2.5 meters tall, and and you jump on her literally because she's got a scale and she weighs you and she gives you your height and she gives you your oxygen, she gives you your blood pressure. So she does a full health check in between 3 and 4 minutes, which is remarkable. And what is profound, so I've spent quite a lot of time in these retail environments with people, is how, first of all, unhealthy generally people are. So blood pressure is generally elevated, BMI is not where it should be, body percentage fat is too high. And so we then give people the results on the app and they're so excited to see, so tell me, what is my body age? And
that is the worst. Don't bring up body age. Yeah, Vitality ruined it for everybody.
Well, so my point really also is to say, how do we empower people? Because a doctor and a tablet is not going to be the end all and be all. It's actually about empowering people. So I'm amazed at how people are unaware of their BMI, of the fact that they have elevated blood pressure because they're asymptomatic. So I think a big part of what is going to happen with digital healthcare, and you can do it on our app, you can do your blood pressure on our app for free, is that you can start monitoring and be empowered. You need your data. You need to know what my blood pressure is, what my weight is, what my weight should be for my height, my body percentage fat. Because then, as hard as it is, and my BMI is not where it should be, and I lead a health tech, but I'm working on it. But it's that ability to change daily habits, which is the hardest thing in the world. But if we can empower people through digital solutions to take ownership of their healthcare, you'll drive demand down. I mean, amputations are the number one reason. The number one reason for amputations is diabetes in South Africa. That is remarkable when it's something that a lifestyle change can cure initially. So I think empowering people to own their well-being is key, and I think health tech can help do that. And I think the second thing then is definitely navigate through your GP and through the nurses. And I don't like the term gatekeeper because as consumers we don't like to be gate-kept, right? But we do need to be directed appropriately and from a value perspective. Don't jump to a specialist at those sorts of rates when actually a GP or a nurse and a technology app can help you.
The confidence that society overall has in nurses. We know that as a country, we have had so many different challenges that have all created this trust deficit in anybody in uniform, right? They've borne the biggest brunt of this trust deficit, and that applies to nurses too. And again, because of the hierarchy that exists in the healthcare sector, right? The nurses, you're bottom of the food chain. So even if I have a nurse in front of me, what I want to do is that I want to see a doctor. It's the culture that we have created in South Africa. Interestingly enough, though, it's not the culture that necessarily exists in other countries. How do we begin to rechange and reshape that culture and give nurses the positions that they actually have in the healthcare system?
So 100% agree with you. I think, and it is a South African challenge, and not necessarily seen in other places. But it wasn't always a challenge. I mean, if we went back 30 years, 40 years, to be a nurse was highly regarded, and it was something that people strived for. I think the challenge is that, unfortunately, the nurses are placed in terms of, the volumes and the remuneration has made the care that they often need to give not ideal. So if the volume of patients are just so high in a public sector clinic, you don't have the time or necessarily, to spend 20 minutes talking about a mental health issue that we should be doing. So I think there's multiple challenges. And that's why I think that digital tools can change that. It's not going to replace practitioners at all. I think what the digital tools allows us to do, it enables us, gives us the opportunity to be able to treat our patients better and actually spend more time. So if we can filter all of that and do that using smart technology, I think we're going to be able to change that view on what we can do. What we are seeing already now is that, the public health sectors and all the clinics are staffed and manned by nurses. Nurses are in charge of most of the screening, and that's where we need to place a lot of our emphasis. I agree completely with Tanya that the reasons why we see a lot of disease burdens is because we're not screening enough patients. We're not picking up the diabetes. We're not picking up the hypertension. And if we can start doing that now, it increases the capacity, allows the nurses to spend more time doing more clinical work. But going forward, I think it's a multidisciplinary approach. I think we shouldn't be putting them into silos, and that's been one of our problems, is that everybody sits in silos and there's no interaction between it. I think if we put a multidisciplinary approach in place, and we can do this now much easier and better in terms of technology, it means that the nurses can see a lot of patients, and should they need to, they can refer to the general practitioner, and should he need to or they need to, they can refer to a specialist in a team approach. And so if we start getting rid of the silos, we're going to build a lot more confidence with patients.
In order to be able to do that confidently, the nurses themselves also have to be empowered with information. So what is happening on the back end of the use of the app, particularly for the nurses now who are interacting with me as Cathy when I'm asking why is it that I have a headache that I can't fully describe or give an accurate description of on the app?
So what we do is when you come onto the app, we ask, you can do your face scan, and then we get your blood pressure and we get your pulse and we get your oxygen levels, and that goes into your profile. Then we ask you about your height, your weight, and whether you're a smoker, and that goes into your profile. And then let's say you have a headache right now and you're worried about it. You can then say, I want medical help. We then pass you into a triage, a digital triage. It's AI-based.
Okay.
And all we want to do is we want to just check at a risk level, is a nurse appropriate, or should you see a doctor online, or should you see a doctor in person, or should you actually be going to the hospital? And that AI, what it does initially is ask you basic questions like a doctor would, like you do in your practice, just what's your family history, etc., sort of about 8 questions. Then it starts interactively asking you about your headache. Where exactly is it? How long have you had it? What's the severity? Other symptoms? And it basically does a diagnosis. And then if it doesn't tell you what the diagnosis is, but based on that diagnosis will then pass you to a nurse. The nurse gets that full record. So we then say to you, would you like to speak to the nurse? And you say yes. You then pay 95 Rand, and we pass you over to the nurse. And what she then does is gets your record. Her skill set, though, is different because she doesn't have the benefit of being physically present. So there's you need very good soft skills. So somebody said to me yesterday, the nurse called her a sir. So you need to be able to listen because you're either you're typing or you're on a video call. So it's definitely a different set of skills that you now need in this digital age. You receive a report. You need strong communication, strong soft skills, because you just don't have a whole context within which to create confidence and rapport.
Okay. We're going to continue this conversation in a moment. Tanya Joffe, CEO of UNU Health, and Dr. Unban Pillay is a medical doctor. It's 11:30, time for the latest news headlines.
Thank you very much, Cathy, and a very good morning. With the news headlines, Kemodupi Makhalemele. South Africans living abroad will vote at different missions around the world in just over a week. Labour Minister Thula Singesi is expected to brief the media following the collapse of a multi-story building in George in the Western Cape. And South Korean President Yoon Suk-yeol has announced that he wants to create a new ministry that addresses the country's low birth rate, calling it a national emergency. Details of these and other stories at noon.
Greenpeace is on a mission for a greener world. We're all about making the switch from fossil fuels to renewable energy because it's just common sense, right? Don't buy into the hype about oil and gas. They'll only make our climate crisis and extreme weather worse. We're pushing for real change, like in Mpumalanga, where we teamed up with MS Environmental Projects, who just won in court against the municipality for pollution. So when it's time to vote, remember to say yes to renewable energy. Swing by greenpeace.org/Africa to join the movement.
Count down the best 41 moments from the last decade of Top Gear every Friday at 9 p.m. from the 3rd of May with Richard Hammond. Throwback to James May, aka Captain Slow, driving up an active volcano. The team goes on an epic supercar road trip through Romania and the unmasking of the Stig. I really thought he was malevolent. This is automotive action you simply cannot miss. Channel your inner Stig with BBC Primetime only on S3. Open up. S3.
EFC is live this Thursday. Two grappling wizards will battle it out for the vacant welterweight title at EFC 113 as Gelson Souza and Zakir Banat fight it out for championship glory. Plus, Faiz Jacobs is out for revenge against the great Sylvester Chipumbu for #1 contendership. EFC 113 live this Thursday. Watch it on SABC Sport Channel on DTT Channel 4 from 7 p.m. Brought to you by SABC Sport.
#SAFM Talking Point.
You're listening to The Talking Point. We continue our conversation looking at how technology is changing the healthcare sector, but most importantly, when it comes to nurses, right? How can technology help make the lives of nurses and the administration of the care that they have to give to you and I a lot easier? Dr. Unban Pillay is a medical doctor. Tanya Joffe is CEO of UNU Health. So how do we get this? I guess it's not just ideas. We have one app to work with. I'm sure there are many others out there that have different types of solutions. How do we get all of this where it's needed the most? So it's one thing having it at a care center down in Sandton, right? But is it really absolutely needed there? Not quite, because the numbers of patients that are being dealt with, not as high. You find that it's mostly private care that is accessible to a lot of people. How do we get it into townships, into Soweto, Chris Hani Baragwanath Hospital, into George Mukari Hospital? Dr. Pillay?
So I think that that is easier than what we think, actually, because already there are solutions. So we have solutions that not just about Gauteng and townships in Gauteng. We can actually go to rural areas. So we have solutions like a point-of-care ultrasound now that we're actually putting in the hands of a nurse, which has an AI-based platform to it that a nurse or even a lower-level care worker can now do a screening on an abdomen, and the AI can work out the gestational age and can work out, is there any abnormalities.
Sure.
There's a solution that can do breast screening.
All of that done on an app.
All of that done on an app with a probe that's probably the size of my cell phone. We can do, it's live, it's available we've piloted it in both Steve Biko and in Grooteskier, in Witkoppen Clinic, where they're piloting a breast screening tool, which again is an ultrasound device that a lower level healthcare worker can use. We teach them how to do 2 or 3 different screening across both, of the breast. And the AI solution is 97% accurate to pick up breast cancer, which is more accurate now than a clinician.
Sure.
And that's available, and we can do that now. So that's going to be solutions, the type of tools we have. Backpacks with connected devices that can do blood pressures and blood glucose and a whole host of devices that we can take into the townships, we can take into rural areas, and we can screen patients at where they live. And so these are all solutions that we have available currently in South Africa. It's just that we might not know a lot of them, but we are definitely using more smart technology and smart solutions to be able to get to the patients to where they are. And so it's not just private sector. It's actually a lot of the emphasis and a lot of the piloting and work is now in the public sector.
Tanya, what gets in the way of the use of some of these technologies? What become the biggest challenges? You could have the best computer in front of you, but often the IT guys talk about a user problem, and they say, you say it's not working, and they say, well, there's nothing wrong with it. It's a user issue.
Oh gosh, I can relate. Yeah. So that's actually our experience has been so profound. Even though we have 90% smartphone penetration, which is actually that's the basis. If you can get a user with a smartphone, actually has access to most of these solutions. Sure. However, data is expensive. My storage on my smartphone, I don't have enough storage space. That's a challenge. And then the other challenge is I might not remember my Google passwords. Yeah. So especially if I'm Google, if somebody set it up for me, I have no idea. And that's what we're seeing right now. We're seeing that the friction is user error, which is so frustrating for users. So what we have to do is we have to design for those. We have to help users through those loops. But the innovation, like what you've just described, that is happening in the healthcare vertical, if we can bring that onto phones and create access that way, we can completely change the quality of care that people can access at the price point. We can literally revolutionize healthcare.
So what is making it difficult to have full-on penetration within the market right now?
So I think maybe cost. I think cost of these solutions, we have to understand, how do they get remunerated? How do the technology companies, the big companies? But what we are seeing is a shift even in all the big companies globally moving into healthcare. So the likes of Amazon, Google, Apple, all of them are looking at healthcare solutions. Google's doing a lot of solutions in AI. And so we're hoping that as the bigger companies and as the big tech companies, as the multinationals get involved, the cost is going to come down. But at the moment, I think what Tanya says around about data, around about, understanding, education is very important. All of these solutions, whenever there's something new, I think we're hoping that as we move on in time, the cost comes down, the ability to use the solutions come down. And we need to make it as easy as possible and as accessible as possible. I think that's important.
Tanya, I'm going to give you the last word in this conversation, your parting shot.
The more consumers we can get to adopt digital solutions, the greater the scale, the stronger our position to negotiate both locally and internationally for better deals and better solutions.
Okay. Well, thank you both for coming into studio today, for making time for this conversation. Tanya Joffe, she's with Unu Health, the CEO there, and Dr. Unban Pillay, a medical doctor also, as you can hear, somebody very involved in digital health and has been advocating for nurses to be given more digital health platforms that they can use to help with their work on a day-to-day basis. All right, we're edging towards the end of the show. Almost there, not quite yet. We're going to take a quick break, and then on the other side of this, I will officially be saying goodbye.
Greenpeace is on a mission for a greener world. We're all about making the switch from fossil fuels to renewable energy because it's just common sense, right? Don't buy into the hype about oil and gas. They'll only make our climate crisis and extreme weather worse. We're pushing for real change, like in Mpumalanga, where we teamed up with MS Environmental Projects, who just won in court against the municipality for pollution. So when it's time to vote, remember to say yes to renewable energy. Swing by greenpeace.org/Africa to join the movement.
Count down the best 41 moments from the last decade of Top Gear every Friday at 9 p.m. from the 3rd of May with Richard Hammond. Throwback to James May, aka Captain Slow, driving up an active volcano. The team goes on an epic supercar road trip through Romania and the unmasking of the Stig. I really thought he was malevolent. This is automotive action you simply cannot miss. Channel your inner Stig with BBC Primetime only on S3. Open up.
S3. Things are really heating up in the Tastemaster kitchen this week as we enter our first elimination challenge.
This week, we celebrate our African pride and see who will rise to the occasion.
10 minutes left and I'm still doing my curd.
Things can go wrong very quickly.
What I'm doing to try and finish on time is pray.
Join us 7 p.m. on SABC2 every Tuesday.
Repeat on Wednesdays at 2 p.m. and Sundays at 4 p.m.
See you there.
The SABC Fortune Combo radio stations, which includes SAFM, Lotus FM, and Radio 2000, seek the services of a freelance graphic designer who will collaborate with cross-functional teams to create visually compelling assets that align with our receptive brand identities and resonate with our target audiences. The minimum requirements for the position are a bachelor's degree or diploma in graphic design, visual arts, or related field, 2 to 4 years proven experience as a graphic designer with a strong portfolio showcasing a range of design projects. All interested candidates should submit their CVs and portfolio of evidence to vacancy@safm.co.za. Application closed on the 26th of May 2024. For more detailed info, visit www.safm.co.za or follow us on our social media pages at SAFM Radio.
SAFM, leading the conversation.
The Road Accident Fund will be announcing winners of the Road Safety School Competition and Youth Projects to be supported by the fund. In August 2023, the RAF launched a comprehensive road safety program for learners and youth. This program involved educating learners in primary schools, special schools, and high schools about road safety through talks, industrial theatre performances, and road safety simulations. The event will be held in Durban on Friday, the 10th of May. For more information, you can visit www.raf.co.za.
The Talking Point with Cathy Mohlahlana. Weekdays, 9 a.m. till midday.
All right, so we've come to the end of the talking point for today. But before I go, did you know that today is 20 years since one of our brightest stars left us, Brenda Fassie? And we're marking 20 years commemorating her life, remembering just what a gift she was. And this particular song, of course, needs no introduction to South Africans, and perhaps is one of the reasons why we loved her so much. She was somebody who made us dance. And so on this Thursday afternoon, I leave you with Vulindlela. Because I have Vulad the Ndlelas, I will see you again, or will be back with you again on Monday. Have a lovely weekend.
Hashtag SAFM Talking Point.
The book reading. Please note the views expressed in this book are not that of the station. Listeners' discretion is advised. SAFM presents another episode of Why Men Hate Women, written by Kopano Ratili.
It must be clear at this point that there are many common insidious cultural myths that calcify misogyny and add to the difficulty of preventing and reducing grave sexual violence and femicide. Setting out to expunge rape myths from one's masculinity, I contend, is not an easy task for most people, and certainly not a once-off task. A person who grows up in a culture suffused with these cultural beliefs, which implies most people, absorbs them into their consciousness. They may even sink into the person's unconscious. We might even say with caution that Malema may actually not have been conscious that these myths were part of his beliefs, of his psyche. Yet, even when a man's critical consciousness with respect to gender and sexual relations has expanded, and he can immediately recognize a rape-supportive attitude in himself, he is influenced by other family members, friends, broadcast media, religious communities, films, advertising, social media, laws, and education systems that constantly reinforce or fail to discourage these myths. Consequently, if we take as our duty the making of a better society, it is society's support of rape myths that we must challenge. 2 years after his statement to the students in 2009, after being taken to court by the human rights organization Sonke Gender Justice and losing the case, Malema apologized. I'm sorry, and very sorry about that, and commit not to repeat a similar mistake again. Issues of women are sensitive, and once a person says, I'm offended, it doesn't matter whether you are right or not. You must have the capacity to say sorry. I want to say sorry to the lady and to the Songe gender, and I commit to pay them that 50,000 rand and pay legal fees for that case. I don't know whether the students saw that apology, and if so, what they learned from it. Perhaps those who saw and read about the mistake may have something like, men can learn. They can say sorry when they are wrong. Maybe they said, that was then and all is fair in the heat of politics. Gender and sexuality are never outside of politics, of course. Rape is never not about power. But that I signal the fact that our identity as subjects of gender power, our words, our beliefs, our acts, including words, our acts of sexual violence, are never outside power. We are positioned by power. Power is part of our being in a society with others. And I want to state again, power is not always negative. It is not only used to injure, subjugate, or control. It can be, and often enough is used to free others, to enable them, and to build space for more people to be happy. I hope that if not those particular students who listen to Malema, then with the help of this reflection, other students, you the reader, will appreciate that rape is enabled by stereotypes about women and men. Rape myths have implications for all forms of violence against women and for broader social relations. Rape is connected to our thoughts, attitudes, feelings, beliefs, and action, which are products of our culture, and culture is infused with power relations. Whatever else we may feel rape is about, it is simultaneously about who has power and to what end they use that power. I also hope that more of us will appreciate that the victim of rape is never to blame. She was asking for it is the classic way a rapist shifts the burden of blame from himself to his victim. The popularity of the belief that a woman seduces or cock-teases a man into rape or precipitates a rape by incautious behavior is part of the smoke screen that men throw up to obscure their actions. The insecurity of women runs so deep that many, or possibly most rape victims, agonized afterward in an effort to uncover what it was in their behavior, their manner, their dress that triggered this awful act against them. What Brown Miller is alluding to here is shame. As Rebecca Hellman has said, the shame belongs elsewhere. In my interviews with survivors of sexual violence, I've heard of a multitude of ways in which women are resisting being shamed. The shame that is attached to sexual violence belongs with the person who holds rape myths, the rapist, and the culture that supports rape. It may not be enough, but all I have is hope and willingness to work against these myths and their effects. For I do not know if the students who heard my lemma say he is sorry quite understand how our attitudes, feelings, beliefs, and behavior support rape and what they do to our society. Chapter 30. Dad, look at me. Dad, look at me, he says. Or simply, Dad, look. An injunction, but also a petition. He's about to jump or to do something else with his body. Human beings are now apprehend better than ever before because of this being who hails me as Dad need to be looked at in a certain way. Being looked at offers a way of looking at ourselves. Without the other to look at us, we travel blind. We need to be looked at as we do not actually know how we look to others. Looking is a form of building the other's self. Love is to be found in a look. It is also true, though, that looking can be used to crush the self. Hatred, anger, disappointment, disgust can be communicated with a look. It is not only joy, camaraderie, recognition, happiness, pleasure, contentment, and care that are found in the way we look and are looked at. I know that in order to experience positive affect in interactions with others, a person needs to be spoken to in a particular way and not in other ways, held in a specific way and not other ways, or of course looked at in a certain way. I know it not as a thought somewhere in my head, but as something that every human being needs, not as immediately as one would need water after a day without drinking, but as much more than mere pleasure. Other people have an influence on our emotions and cumulatively on what we become. Even though feminism teaches us we have to resist the male gaze, it is common knowledge that we dress up for others, whatever gender we are. We instinctually crave the father's gaze as much as the mother's gaze. We apply makeup and put on earrings and our beautiful shoes and check ourselves in the mirror so as to look at a certain way for an imagined audience. Those of us who grew up under colonialism and legalized white racism wear certain clothes and on Sundays put on our best clothes because somewhere deep inside us, what we wear makes us feel good, since others look at us with envy or a sense of wanting what we're wearing. It was Freud once again who alerted me to the idea that being looked at is libidinally exciting. I found this to be so. Yes, we get excited at seeing others look at us. It is, however, a very strange pleasure indeed being looked at. At the same time, we derive from others' eyes more than pleasure. It is not just the psychical enjoyment that we get from being looked at by our fathers. We also seek something of this very excitement in the eyes of the security guard outside the store or of our co-workers. It is then not merely thrills that we get from being looked at. Rather, what we are looking for is something much more ontologically reinforcing. We want to be noticed. Humans are always looking for a kind of recognition that they exist. We do not eat being looked at. We do not smell it. It does not keep us dry when it rains or safe from those who would hurt us, even though there is a way of hurting from not being looked at, or from being looked at in a way that misrecognizes us, takes something from us. And yet we put on a lot of psychosocial energy into receiving good looks of recognition, sometimes even of approval. Many of us will buy new clothes to appear pleasing to others' eyes. Some of us purchase beauty products to make ourselves look attractive. And others will even undergo